Good morning or afternoon, everyone. My name is Dr. Dan Bouvier, and I am an orthopedic surgeon at the New Hampshire Orthopedic Center, specializing in sports medicine. And I'm here today to present to you some things about on-field management of common joint dislocations. I have no financial disclosures, and I'm currently serving as the team orthopedic physician at Bishop Gorton High School. So, some general observations: joint dislocations represent up to about 3.6% of all high school athletic injuries. And so you as athletic trainers will certainly see many of them, and certainly prompt diagnosis and management can improve outcomes. Depending on your knowledge, training, and clinical experience would dictate how much you get involved with the actual treatment and or reducing of these dislocations. But certainly we can improve on outcomes by diminishing pain and diminishing the risk of neurovascular compromise and also chondral injury. Some of the objectives for today will be to review some anatomy, some of the causes and mechanisms of injury that you'll encounter for joint dislocations and injuries with a focus on the shoulder. We'll talk about diagnosis, precautions, indications, and techniques for reduction a little bit as well, again, with an emphasis on the shoulder. Some general rules of thumb to think about. Neurovascular exam before and after is very important. That is something you'll always want to document before and after a reduction. In terms of reductions of dislocations, the sooner the better. And beware the pediatric patient, even the adolescent patient, because one of the other caveats to all of this, or pitfalls to all of this, is that you certainly don't want to be yanking on a shoulder or some other joint that's actually fractured. And even adolescents can have open growth plates in and around the shoulder in other areas. And so that a fracture could be the problem and not a dislocation. That's one of the challenges, not having on-field radiographs to help you. And also multiple attempts at reduction is not recommended. So let's start with the shoulder, a little bit on the anatomy. It's the most mobile joint in the body and is very shallow. It's really a ball on socket joint, not a ball in socket joint. And so for that reason, it relies quite a bit on soft tissue for stability. And because of that, is also susceptible to injury. There's a spectrum of disease in terms of shoulder instability from traumatic to non-traumatic, but certainly you'll be seeing the traumatic injuries, but they may be superimposed on a multi-directional shoulder instability patient, for example. So the increased mobility allows for extremes of motion, but that can place unnatural stress on the soft tissues around the shoulder, making it susceptible to injury. The osteology of the humerus is pictured here. The humerus, the scapula, and the clavicle make up the shoulder girdle. You can see here that the shoulder blade does not sit flat, perpendicular on somebody's back. It's antitilted or antiverted forward about 30 degrees from the flat of the back. It also upward tilts a bit. And the angle that the humerus makes with the shaft is about 130 to 150 degrees as well. This shows you a little bit more about the orientation of the socket as it relates to the body of the scapula itself. And there's something called retroversion of the glenoid, and there's also retroversion of the humerus. That really means where does the articular surface face in relation to the regular axis of the bone. The humerus averages 30 degrees of retroversion, and the glenoid about 7 degrees of retroversion to 0. Then there's the soft tissues, the glenohumeral ligaments being the primary ligamentous stabilizers, and those attach, of course, to the glenoid labrum. You have the superior glenohumeral ligament, which is less distinct when you look inside of a shoulder. The middle glenohumeral ligament is easy to find as it drapes right across the subscapularis muscle when you're looking in the shoulder, for example, arthroscopically. The long head of the biceps is up top and inserts on the top of the glenoid. And down here is the axillary pouch. The most important thing here is that you'll see that there's no rotator cuff tendons down here. which is why when the arm is in abduction and external rotation, in most dislocations go out the bottom toward the front, because that's where there's no rotator cuff to protect it, especially with the arm in that vulnerable position. The labrum itself deepens the glenoid and adds some surface area. This is a good slide that really demonstrates the angle of pull of the rotator cuff and its job, which is essentially to compress the humeral head into the center of the glenoid so that the deltoid, which has the longer lever arm and is the larger motor, can operate the shoulder. Shoulder dislocations are more than half of what you'll see in terms of joint dislocations, 95% of them being antero-inferior. And recall that the patients may already have a history of this. It's probably 50-50, I bet, in terms of whether you'll see somebody's first dislocation or whether they'll tell you when you get out there that they've already had one or two or more than that. This is just an X-ray showing an anterior-inferior dislocation with the humeral head down in that antero-inferior quadrant. You can see the whole glenoid, which is not normal to see. So when you evaluate these patients, you want to think of that. Any prior history? Is this a patient who has had dislocations and self-reduced? What was the mechanism of injury? Did you see the play occur? And if you did, what was the position of the arm? Was it a direct blow? What type of injury could it have been? Because that may also indicate whether or not you think there could be a fracture instead of a dislocation. The patient telling you what they feel will also be helpful. Was there grinding? Is there cracking? Especially if you attempt to move the patient. This is just a picture of what it would look like. The patient usually is holding their arm slightly abducted away from the body. They're holding their wrist with the opposite hand. You'll see here, the acromion becomes very prominent, and there's often a prominence anteriorly, depending on the body habitus of the patient, where the humeral head will be palpable. These are special considerations for other dislocations. This is luxatio erectae on the right side here. This is an X-ray showing a straight inferior dislocation. As you can see, the humerus pointing straight upward. These patients will literally present with the arm up over their head stuck there. That needs to be sent, likely to be relocated at the hospital. This is a posterior dislocation where you'll see that the coracoid looks more prominent. There's a dimple in the front and a humeral head more prominent toward the back. The initial presentation of a traumatic dislocation is that which we just saw in the picture. Arm slightly abducted, cannot internally rotate, and lacks full elevation. There's an anterior fullness present. Remember posterior dislocation, remember the history. What position was the arm in? Offensive linemen are some of the players who will have posterior problems from having the arm forward flex straight in front of them and getting the arm driven posteriorly with a force directed from the front to the back. A posterior dislocation, we saw the picture of it just prior to this, they'll be unable to externally rotate beyond about 0. And again, the coracoid may become prominent anteriorly. Very important to do a neurovascular exam, critical before and after the reduction. This will be a recurrent theme. The axillary nerve is the most commonly injured nerve and can be upwards of 20% because many are not recognized. You also want to check the musculocutaneous nerve, but really all of them. Do a thorough neurovascular exam. The axillary nerve provides sensation over the deltoid. The musculocutaneous nerve, you can test with pronation and supination of the forearm, as well as medial antebrachial cutaneous nerve sensation. You want to have a high index of suspicion for fracture, especially in that pre-adolescent group, 10, 11, 12, 13 years old. Their humeral growth plate's still open, and they can have a proximal humeral fracture. So you want to palpate the entire shoulder girdle and the elbow, wrist, and hand. Also feel for asymmetric pulses or asymmetric temperature that might indicate some sort of rare vascular problem. An expanding hematoma in the axilla would be another reason, combined with diminished pulses or a cold arm is an emergency, and you just send that patient away to the hospital. We'll get into a little bit with techniques here. So this also goes back to the discussion earlier about your experience here. So if the doc is with you and you've learned some of these things, then it's really going to be the physician's discretion, as per your athletic trainer's position statement, about what's allowable to reduce and what you feel comfortable reducing. Obviously, having reduced some shoulders in the past, you're going to feel more comfortable with that, then you go ahead and do it. Certainly that has a lot to do with it. I like the traction counter traction technique here, but this does require somebody to help you. Typically, you can do it by yourself, but with somebody helping, it doesn't have to be a trained person. All that person's going to do is hold on to this sheet or a towel or whatever it is you may have to hold the rib cage there while inline traction is pulled. And this is the exact position. You bend the elbow 90 degrees, pull traction, and with gentle rotation and abduction, the joint will reduce. This is called the Stimson technique. And this is if you get the patient off the field, you can put them on a training table. If you want to tie some weights to their wrist and let them just hang out there, you can come back 5 or 10 minutes later and it's probably going to be popped in at that point. This is called the Spasso technique, and this is one that you can do by yourself. And that requires that you just start to place vertical longitudinal traction and forward flex the arm while gradually externally rotating the humerus. This has been successful upwards in the mid 80% of the time and can be done by yourself. You just have to coach the patient in terms of relaxation. Most of these things are going to work better the sooner you get to the patient. The benefit of on-field reduction is that muscle spasm hasn't quite set in yet. So you're able to get these in before significant muscle spasm occurs. So usually the reduction is a little easier. By the time they get to the hospital, they'll often require sedation, and a lot of it at times, because if they don't sedate the patient enough, they have to pull really hard. And this is where nerve injuries can occur and secondary injuries from the attempts at reduction. This is called the Lydelmeyer technique. And what this is by adducting the upper arm to the side with gradual, progressive, slow external rotation and a little bit of flexion, the shoulder can reduce. By the time you get to 90 degrees of external rotation, if in fact the patient has that much, you should notice that it has reduced. Once reduction is obtained, recheck the neurovascular status, make sure you have good pulses, good sensation, immobilize the patient in a comfortable position. And this goes for if you are unsuccessful as well, and then refer to urgent care for a set of x-rays. If you are unsuccessful at reduction and you're not sure it's in, maybe to the hospital, and then orthopedic follow-up. But you'll feel it go in. The patient is relieved and will immediately tell you that. Elbow dislocations are a little more complicated and less common. The elbow's a trochoginglymus joint. It's got a hinge as well as a rotatory component with the radiocapitellar joint. Usually these injuries are the result of a fall on an outstretched hand, and most are posterolateral. You can see in the x-rays, although I like my x-rays the other way around, this is a posterior dislocation. So you can see that the olecranon or the proximal ulna is behind the humerus. And it's also, the forearm is also lateral. So posterolateral refers to the direction of the distal portion. So the distal portion of the limb is posterior and lateral. That is the most typical ones. And this is why the MCL is often injured, the UCL is often injured. There'll be an obvious deformity with a prominence posteriorly. There'll be pain with attempted motion, of course. Again, neurovascular exam is important, checking especially the ulnar nerve, radial nerve. Be aware of the pre-adolescent or adolescent, because there is a significant incidence of the medial epicondyle avulsing from the distal humerus, because it is a apophysis at that point. So medial epicondyle entrapment in the joint may prevent reduction. And so we have to keep that in mind. There are times, though, that reduction is successful and the epicondyle goes back into position. This is a joint which isn't always cleared for reduction on the field. If the physician is there and it has experience with it and is able to show you, then certainly it's worth an attempt for sure. I like the technique on the left where the patient is laying on their belly with the elbow bent over the edge of the table. That way you can use your thumb to feel the position of the olecranon in relation to the humerus. The idea is to first correct the mediolateral translation, and then with traction and using the thumb to push the olecranon with very slight extension, you can hook that coronoid process of the ulna back onto the distal humerus. This is another technique with traction and manipulation with the left hand by pushing the olecranon back over the trochlea onto the distal humerus. Correct coronal plane first, and then the thumb pushes the olecranon. After reduction, which will be obvious as well, these are generally fairly stable. You immobilize at 90 degrees of flexion and pronation and check a neurovascular exam. Prompt x-rays after that to confirm reduction, but also to evaluate for associated fractures. In adults, the radial head and coronoid are not uncommon. Again, in children and adolescents, the medial epicondyle can be a problem. If you can't get it reduced, splint it in a position of comfort. Wherever the patient is more comfortable would be better. You don't want to force the elbow into flexion of 90 degrees when it's still dislocated. Fingers are often downplayed, but often very obvious as well. You can obviously see a deformity. PIP joint is fairly common. This is an x-ray of a dorsal dislocation here, and this is a picture of a volar dislocation with a little bit of a fracture as well. And that's something that is not uncommon to have associated fractures of the volar plate avulsion or the central slip on the dorsal side. PIP reductions certainly can be attempted on the field. Dorsal dislocations require that you hyperextend the distal fragment to accentuate the deformity and then push the base of the middle phalanx up and over, just like is pictured here. A little traction, extension, and push the base of the middle phalanx up and over. Extension will relax the tendon structures as well. If you're talking about a volar dislocation, you want to flex the middle phalanx so that you can then get the dorsal lip of that middle phalanx up and over and back onto the proximal phalanx. So it's just the opposite maneuver, but you're pushing the base of the middle phalanx back up and onto the proximal phalanx. Once it's reduced, they could be splinted and taped up and can finish the game. But you want to make sure that the dorsal dislocations are immobilized in slight flexion so that the volar plate, which is usually injured, can be reapproximated and start to heal. Volar dislocations should be immobilized in extension to try to reapproximate what could be a central slip avulsion. That can also be checked with an exam to make sure the patient can hold isometric extension and they can finish the game. But they do need hand surgery follow-up relatively promptly because long-term deformity and dysfunction is possible. And this is where the downplaying of these injuries can be a problem. If you look at old NFL players' fingers, they are really gnarly because many of them just pop their fingers back in and never sought care. And for a while, the finger works fine. And then as time goes on, they start to notice either a swan neck deformity or some other late deformity due to collateral ligament injury and or central slip tendon injury or volar plate injury. So the finger starts to drift into a deformed finger and function can really be affected. So hand surgeon follow-up is really key here. Going on to the knee dislocations in and of themselves are pretty unusual. However, they always need to be suspected, especially with any kind of multiplanar sloppy knee after an injury. You could have a knee dislocation that has spontaneously reduced and even x-rays could look normal. But with any multi-ligament knee that's unstable in more than one plane, that could be a dislocation that has reduced. So this can be an emergency. The key here is pulses. This is an X-ray showing an anterior dislocation here where the tibia is completely in front of the femur. You don't like to even see an X-ray like this. You would much rather have somebody in the field having reduced this to try to restore blood flow, because this is all about a vascular injury that is a potential problem. Popliteal vessel injury is a real thing, as is perineal nerve injury. Pulses, pulses, pulses. Check the pulse. If there's any asymmetry in a healthy young person with their foot pulses, then we need to immediately suspect potential vascular injury, get that patient rapidly transported to the hospital. They may need angiogram to rule that out. Now, reduction is usually not that difficult. Simple traction and extension to put the knee in better alignment, you'll notice it reduce. It may be very unstable, but you want to try to just get that knee looking more straight. It sounds simple, but if it's that injured that it dislocated, it's going to be fairly simple typically to get it lined up. Knee immobilizer and then to the emergency room. This is far more common, and you will see many more of these than anything else in terms of the knee, especially in the adolescent population. The patella is the largest sesamoid bone in the body, and the dislocations are typically lateral, as you know. It's the dislocations that are subluxations or spontaneous reductions that can sometimes be a little tricky, because the pop can make it seem like an ACL injury, especially with the spontaneous reduction. But as you can see here, this is a lateral dislocation, and the reduction maneuvers, fairly simple. It's really just extend the knee and push it over, the patella that is. By straightening the knee, usually the patella will snap back into its trochlear groove, but sometimes if it's significantly out and tilted, it does require a little bit more manipulation, but the extension of the knee will really help. So it's a simultaneous extension of the knee and a pushing of the patella back into position. If anyone saw the Chiefs last year when Patrick Mahomes dislocated his patella, you could see the gentle reduction maneuver performed by the trainer on the field. And I was going to put a video up of that, but it was too long and I couldn't crop it because it was YouTube's. So weight bearing is tolerated once it's popped in orthopedic follow-up. Now, ankle dislocations can be tricky because a straight ankle dislocation is really not very common. Talocrural dislocation is the ankle itself, which means that the talus is dislocated out from under the tibia. Subtalar dislocations are much less common. It's when the talus dislocates, the subtalar joint dislocates, so the calcaneus dislocates from the talus. Ankle dislocations are usually the result of a fracture. So the evaluation is going to be looking for the deformity. This is a subtalar dislocation, and you can see the talus is still under the tibia, but the calcaneus is displaced out from under the talus. Check for skin tenting or wounds. So whenever there's an ankle deformity, you need to get the socks off, get the ankle exposed, and look for open wounds. Is the whole foot displaced or is the heel displaced? That's how you can tell the difference between the subtalar dislocation and the ankle dislocation. Here's an ankle dislocation here. You can see this is the medial malleolus tenting the skin. That's a fairly typical deformity. The talus is usually dislocated laterally and posteriorly. And you can see that there's a deformity toward the back here. The whole foot is displaced posteriorly and laterally. This is more of a subtalar dislocation appearance, where the foot and the heel look a little displaced, but the ankle sort of still there, just a little tenting laterally, but it's different than the whole ankle. Here's another ankle one right here. So reduction attempts for the ankle, and even if it's fractured, you want to get the ankle relocated. Usually, as I mentioned, the ankle's out laterally and posteriorly. What you really want to do is get into a position where you can flex the knee slightly or a lot so that it really relaxes the gastroc and the pull of the Achilles, which will fight you here. I like the technique of putting one hand on the tibia and grasping the calcaneus with the other hand. You're really pulling the talus back under the tibia and then pushing it over back to whatever side it came from. You can't really over reduce that. So if the ankle is out posterolaterally, like it usually is, these hand positions would be switched. This hand would be right on the shin, and this hand would be on the calcaneus, pulling it forward and pushing it and inverting the foot and ankle. So you really want to push that talus up against the medial malleolus and pull it under the tibia. You're trying to put the talus back underneath where it belongs. There's an audible snap, and you can tell that it's back in place. However, when you're splinting it, it will pop right back out again if it's fairly unstable, which many of them are, depending on how many bones are fractured. So you need to have somebody help you to hold that ankle reduced while you're putting the splint on. The splint should be a U-splint and a posterior splint. So you want both. This was the only decent picture I could find of this, but putting a simple posterior splint might not be enough, because if the fibula is fractured, the talus still can slide out to the side. So you want a stirrup and a posterior splint, in my opinion, and also invert the foot or evert it, depending on which direction it came from. A pneumatic boot or one of those pneumatic fancy big boot splints is certainly adequate as well if you have access to one of those. That can really make the patient a little bit more comfortable. So in conclusion, sideline reductions or joint dislocations can be of significant benefit to the patient for both short and long-term benefit. But consider your surroundings, the help you have available. Is there a doc present with you, clinical experience that you have, and comfort level with these reductions? We got to weigh the risks and the benefits and the possibility of associated fractures prior to proceeding. You don't want to have multiple attempts that might cause further damage, and prompt referral when necessary. So in going through the National Athletic Trainers Association position statement, there are state and institutional regulations preparing these things. So you consider all those in preparing your protocols regarding joint dislocation treatments, including reductions. And I think many of them in the statement surrounded more dealing with the clinical training, clinical experience, and the presence or absence of a physician in terms of what you would reduce and what you would send. In my opinion, I think the elbow is the more complicated dislocation that is difficult to get sometimes. And if you've never done one, and many people haven't, and you don't feel that comfortable, then referring that right away is not the wrong thing to do. Just get the patient shipped quickly to the hospital where somebody can reduce that. And also, I didn't go into the hip because it's pretty rare, and most people are not going to be attempting a hip reduction on the field. But certainly hip dislocations can be catastrophic, and they're actually an orthopedic emergency. So prompt reduction is key. But if you remember Tua Tagovailoa, who's now the Miami Dolphins quarterback, when he dislocated his hip at Alabama, they did not reduce it on the field. They just put him on the stretcher and got him out of there. And the same thing with the Harvard quarterback that had happened to 2 years ago as well. So if the doc is there, you could do it together, and if that's the suspicion. But otherwise, prompt escort to the emergency room is critical in that situation. Also, your guidelines would also mention is that make sure you have consent before the season even begins from the parents as part of your waiver that would allow you to do these reductions. So if that's not filled out beforehand, you're not generally going to be able to track that parent down if you're going to do it on the field. So thank you very much. I hope this was helpful, and I think we'll go through some questions via email, as Sandy has mentioned to me. So thank you, Sandy, for asking me to do this, and I hope it was helpful, and suggestions for future ones are certainly I am open to. So thanks very much.